Hello and welcome. My name is Dr. Uloko. I'm an assistant professor at the University of California, San Diego, with a focus in comprehensive sexual health, reconstruction, and prosthesis. And today we will be discussing hormone replacement therapy in menopausal patients. So, what is menopause? So, I think a really easy summary of menopause is when your period stops, your hormone production stops. Menopause can be broken down into three phases. There's perimenopause, which are the 5 to 7 years before menopause when your ovaries slowly produce less hormones. Oftentimes, people are symptomatic in that standpoint. That's where they start getting the systemic symptoms, hot flashes, night sweats, and then also the local symptoms of vaginal dryness, increased urinary tract infections, or the urinary tract symptoms. Then there's actual menopause. So menopause refers to the time when your menstrual period actually stops for at least 1 year, and then after that period is postmenopause. So like I said, with the loss of hormones comes the significant symptoms, hot flashes, insomnia, mood swings, and then the significant urogenital symptoms. And these tend to be long-term without any sort of treatments. Other symptoms, signs and symptoms of menopause are osteoporosis, increase in fat, decrease in muscle, and then also decrease in overall cardiovascular detriments. Oftentimes as urologists, we are asked why should we care about menopause. We do urology, but if you want one thing I always say is a healthy vulva is a healthy bladder. If you do not have a healthy vulva, you cannot have a healthy bladder. So one of the things that I always talk to my patients about, especially my postmenopausal patients, is the importance of maintaining vulvar health. We would never, ever, ever just if there's the word vaginal atrophy is such an interesting word that we kind of really accept as a medical community of, oh yeah, that's just something that happens. It's something that happens, but it's something that actually is very preventable. We would never if there was something called leg atrophy, if all we just had to do was, put lotion on our leg and forget and not have our legs completely atrophy, we would do that, right? And yet, versus when it comes to vaginal atrophy, we're not very proactive as a urologic community about ensuring optimal vulvar health and preventing vaginal atrophy symptoms. And because of this, there's so many increased risk and increased undue burden for patients. Patients undergoing menopause, that takes up quite a bit of healthcare dollars, up to $3 billion annually. And a good chunk of that are patients coming in with lower urinary tract symptoms. So because most people here are not sexual medicine doctors, I am going to go kind of briefly through the treatment options, but I'm going to spend more time on the local hormone replacement. So, kind of just basic treatment options or lifestyle modifications. So, exercise, prioritizing mental health, well-balanced diet, support groups, non-hormonal options. It's SSRIs, moisturizers, mindfulness programs, and hormones, And so I think one thing I'm going to really spend a lot of time is talking about hormones and why they matter. Oftentimes as soon as I mention hormones, everyone just says, but they're dangerous. And where did this notion come from? This notion came from actually the Women's Health Initiative, which was a randomized controlled trial that started enrolling in 1998. Prior to that, hormone replacement therapy was actually very ubiquitous in the United States. It came from the European market. And in the 60s, 70s, 80s, everyone was on hormone replacement therapy because they knew how improved the quality of life was. And so the United States decided to do a big study to look at the safety and efficacy of hormone replacement therapy. They actually had to stop the study early because of adverse cardiovascular events. Once they stopped the study, it then went to the media that hormone replacement therapy is dangerous. People are dying being on hormone replacement therapy. And then that then set forward this whole pathway of, up to, I think, 60% of providers in the United States felt comfortable prescribing hormone replacement therapy until this study, and now that number is down to 11%. And if you actually look at the data in the study, when they actually did risk and age analysis and reanalyzed the data, they actually found that systemic hormone replacement therapy was actually very safe when you started it within 10 years of menopause or before the age of 60. It actually prevented against colon cancer, prevented against endometrial cancer, obviously prevented against all of the detrimental effects of quality of life, prevented against osteoporosis, prevented against lower urinary tract symptoms, and just overall better quality of life for these patients. So, and also great cardiovascular health, preventative against any sort of cardiovascular disease. And this is where, and this is why it's important when you're doing studies, is that you're doing studies well. Because the study, when they enrolled patients, the average age of patients was about 75. That's almost 35 years past menopause, they're almost 30 years. And that's, I mean, if you give a 75-year-old anything unmonitored, there is a potential risk for adverse effects. So, in conclusion, hormone replacement therapy is safe. And we've talked about this in the last lecture about, the hormones that we're replacing are not only estrogen and progesterone, but you also make a lot of testosterone. And so it is important to replace that. So systemic hormone replacement therapy is safe, effective, evidence-based. Whenever you are doing estrogen in the setting of someone with a uterus, you always want to make sure that you're also doing progesterone, and then also testosterone is indicated. And we talked about this in the last lecture, but indications for testosterone usage are with postmenopausal patients with low libido. So what I really do want to spend a lot more time on is local hormone replacement therapy, because that's what we do. I think there was also a question about whether or not we use BioT. Don't use BioT. Never start with BioT for patients. It's just very much a gimmick. There's no reason as to why people should start off with these high levels of testosterone. So we're going to go just the nitty gritty. What can I do in my practice to help my menopausal, postmenopausal, perimenopausal patients? And that is local hormones, and that is combating the effects of menopausal changes. So when we talk about vaginal atrophy, I think we need to start talking about it from a standpoint of we are literally having significant changes in our anatomy solely because of negligence. There should be no reason as to why these patients have any sort of changes in the vulva, because we have really obvious, easy ways to fix this and prevent this. So let's see what happens when we lose hormones. So things that happen to the vagina is that we actually lose vaginal thickness. We have reduced blood flow to the vagina, loss of rugal folds, decrease in vaginal length. There's also significant changes to the vestibule. So if I always tell patients your vulva should be a diamond, and when you start losing hormones, that diamond starts shrinking even more, and that leads to significant symptoms. And then also, if you now have loss of good bacteria, because without estrogen, you cannot have good bacteria, what keeps your vagina very acidic. You now have rampant bacteria in the vagina. And then you're also then losing the architecture between the urethra and the vagina. It's like a perfect storm for, cross contamination over and over again. And all of this can be prevented if we are just very proactive as a medical community about preventing these things. The amount of healthcare dollars that would be saved by making sure our patients are on hormone replacement therapy. As we are doing PSA screenings and so adamant about PSA screenings, we should be so adamant about our vulvar health screenings, because without a healthy vulva, we cannot have a healthy bladder. If you notice, this structure here is the vestibule. This is a endodermal structure that is very similar to the bladder. If you have changes significant with vestibulodynia or GSM, it's an unhealthy bladder. And so how do we then fix this. So this is FDA. There are many FDA approved treatment options now for hormonal local hormone therapy. And so take a picture of this. So this is what you should be prescribing to your patients and making sure that they're on it. And then also making sure that you're showing them where they're putting this. Oftentimes most people have never looked down there. And so you can't tell someone to like, oh, just put something on your elbow, and they've never seen their elbow. You have to show them. And then also explain to them why it's important. Again, if you just told me to put a cream on my elbow, why? And explaining to them, you're putting this medication on to keep and maintain your vulvar health, which is ultimately what's going to prevent you from having all of these downstream effects. So really making sure that we as a medical community, we as urologists are fighting and advocating for optimal vulvar health, which is ultimately what is ultimately optimal bladder health, and making sure that we're screening all of our patients in their perimenopausal, menopausal, and postmenopausal age to be using it. And they're also for the patients that are not able to take estrogen, even though there's been no studies showing that there's no effects of local hormones and the correlation of breast cancer. It's safe to give to breast cancer patients. I give it to them all the time. I talk to their oncologists. Oncologists are so on board with it. And there's no studies that shows that there's an increased risk. But if your patient is very scared of hormones in general, there's also things like SERMs. So these are selective estrogen receptor modulators that are great for patients that are not safe to take hormones or don't feel comfortable taking hormones. And so there should not really be an excuse from our standpoint as a medical community to ever let our patients, tissues atrophy and get so unhealthy. We should be really advocating for that. So with that, I'm happy to take any questions. You can feel free to email me at muloko@health.ucsd.edu.